name is Callie Zhou. I wanted to thank the SCSG organizers for inviting me to provide this update on hepatitis B today with abstracts from AASLD and EASL. Here are my disclosures. All right, so it's been an exciting few years for hepatitis B, and this year was definitely no exception. So it was difficult to choose from the many outstanding abstracts and oral presentations that were presented at these two conferences. So I structured my talk on the basis of three main domains, all related to Hep B treatment. So the first is updates on developments with established first-line HBV therapy, so that would be tenofovir and entecavir as well as TAF. Secondly, we will be discussing updates on data on safety and efficacy of withdrawal therapy for patients who are currently on treatment. And lastly, I will talk briefly about some novel therapies in the HBV pipeline, certainly not the entire gamut of options, but really focused on a representative set of treatments that are beyond preclinical studies and are being studied in human subjects. Okay, so starting with established therapy. The first study looked at renal function, so long-term changes in renal function in entecavir compared to tenofovir-treated patients. This is the REAL B cohort. And the rationale for this is that while tenofovir has known renal side effects, there's still conflicting data on whether long-term tenofovir is associated with higher risk of renal impairment compared to entecavir. And there's a paucity of data in diverse real-world settings. So Dr. Mack and his set of investigators looked at the longitudinal EGFR in a large cohort of CHB patients by type of NA, and also looked at the factors that are associated with EGFR decline. So in this retrospective study of 6,189 treatment-naive CHB adults with more than 1 year of follow-up at 22 centers across the US and parts of East Asia, 60% were on entecavir, and about 40% were on tenofovir. They used a generalized linear model. So this is a statistical method to look at longitudinal data points, so multiple repeated data points over time. And they calculated EGFR by the CKD-EPI formula, which includes age, gender, race, and creatinine. We looked at it from baseline and every 6 months. Then they also created propensity-matched cohorts to look at incident renal impairment. And they'd find incident renal impairment as an increase in one or more stage of CKD. And these cohorts were matched on factors that were likely to influence renal function. And they stratified on baseline renal function, EGFR over 60 versus less than 60. So in their cohort, entecavir-treated patients at baseline were older. They were more likely to be cirrhotic, had more diabetes and hypertension, and had a lower EGFR at baseline. And in the propensity score matched cohorts, in the group with an EGFR less than 60, they found that tenofovir was associated with an increased risk of renal impairment with a hazard ratio of 1.3. ALT and albumin were also factors that impacted renal impairment. In the EGFR over 60 group, tenofovir was the only factor, and this was associated with a hazard ratio of 2.6. Now, this is their generalized linear model, and this model was adjusted for diabetes, hypertension, and cirrhosis specifically. And what they found was that the mean EGFR after a duration of 10 years was lower and statistically significantly lower in the tenofovir group at 82.5 compared to entecavir at 83.6. Now, you'll see that although this is statistically significant, the actual difference in the mean EGFR was pretty minimal. When they stratified their data by age, those over 50 and those under 50, the lower GLM adjusted mean EGFR for the tenofovir group was only seen in those that were older than 50. So they concluded that the lower mean EGFR over 10 years among those treated with tenofovir suggests that tenofovir should be used more cautiously in patients at higher risk for renal impairment, particularly those that are older than 50. So the second study looked at HBV DNA integration, which is known to randomly occur throughout the host genome, but particularly in coding areas. And it's an area of interest because it's been associated with the development of HCC. Now, the short and long-term impact of NAs on HBV DNA integration is still unclear. So Dr. Chow presented the study to study the effect of long-term NA treatment on the extent of HBV DNA integration in patients with Hep B. So this was a paired biopsy study performed out of Hong Kong. They had 28 patients who had biopsies collected before treatment as well as 1 year after treatment. An additional 5 patients had 1 more biopsy at 10 years. They used a highly sensitive PCR method to identify and quantify the viral host junction. So restrictive enzymes cut at both viral and host DNA. And then this was further PCR amplified. And the measure for integration they used was called the hepatocyte clone size. So this is the number of detectable bands containing a particular integration at the greatest dilution multiplied by the dilution factor. So of the 28 patients, 50% were E antigen positive, 75% were male, mean age was 40. They were either on lamivudine, talbivudine, or entecavir treatment. Integration did occur randomly on all chromosomes except for chromosome Y, and it was detectable in all baseline and 1-year biopsies. So the first figure here demonstrates the lack of correlation between hepatocyte clone size and baseline E antigen status. Furthermore, there was no correlation between clone size and age, serum intrahepatic HBV DNA, and intrahepatic CCC DNA. There was also no correlation with on-treatment reductions in serum and intrahepatic HBV DNA. However, if you just look at the hepatocyte clone size alone, at year 1, there was a statistically significant reduction at a median of 42.5% in clone size compared to baseline. And intriguingly, 3 of 5 of the 10-year biopsies had undetectable HBV DNA integration. So they concluded that therapy with INAs did reduce the clone size of infected hepatocytes, and long-term therapy demonstrated a marked impact on HBV DNA integration. And this does provide a potential mechanism for the reduced risk of HCC in INA-treated patients. All right, so our next study is comparing tenofovir and entecavir use on patients who have HPV-related HCC and undergo curative hepatectomy. So this is the same group from Korea that originally put out this provocative study that tenofovir treatment may be associated with a lower risk of HCC compared to entecavir. Now they looked specifically at a cohort of patients who underwent curative hepatectomy for HPV-related HCC and compared recurrence-free and overall survival between the two groups. So this retrospective cohort included 1,695 patients in Korea at a single center between 2010 and 2018. And after their curative hepatectomy, and these were all very early stage patients with preserved liver function, the patients either continued in NA therapy or started receiving NA therapy within 3 months of their surgery. About half received entecavir, half tenofovir. They looked at their primary outcomes using 2 methods. So one was a propensity score matched method, including 567 pairs, and they matched on 20 variables. So variables related to both demographic, host, viral, and tumor characteristics. And they also did a multivariable adjusted Cox regression. So in this cohort, mean age was 55 years, 76% were male. You'll see here that the entecavir group did have more cirrhosis and had longer median follow-up because tenofovir was introduced later in the Korean healthcare system. At 3 years, the cumulative incidence of HCC recurrence was 33% and was significantly lower in the tenofovir compared to the entecavir group. Overall mortality was also lower with tenofovir in both the propensity score matched analysis as well as their multivariable adjusted analysis, and that hazard ratio was 0.62. Now, they found that tenofovir therapy was protective for both early and late HCC recurrence, and they divided that at 2 years. And you'll see that the magnitude of the protective effect did increase after 2 years. And the author suggested that maybe this means that tenofovir is more protective against de novo HCC tumors. Interestingly, they also found that the effect of tenofovir was really upon intrahepatic tumor recurrence, whereas rates of extrahepatic tumor recurrence were the same for 2 groups. So among patients who undergo curative hepatectomy, tenofovir was associated with better recurrence-free and overall survival, although I do think the data needs to be validated and there is still a concern for residual confounding. So our last study is on TAF and the use of TAF for prevention of vertical transmission of Hep B. So prevention of mother-to-child transmission is still very critical to viral elimination. TAF, which is a prodrug of TDF and was FDA approved in 2016, delivers higher metabolite activity in cells, but has lower plasma levels. So that leads to a better safety profile. Now, TDF is pregnancy class B and does have well-established safety data. So Dr. Dean here presented data to look at the efficacy and safety of TAF to prevent the vertical transmission of Hep B in a multi-center single-arm retrospective cohort study across 7 centers in China. They included mothers who were mono-infected, e-antigen positive, and had an HPV DNA over the amount that we would typically use to prevent transmission. They received TAF from the 2nd or 3rd trimester until delivery. All infants did receive standard of care HBV and HBV vaccine. Their primary endpoint was the mother-to-child transmission rate at 24 to 28 weeks of age, which is approximately 6 months. Their secondary endpoint was HPV DNA reduction at delivery. They looked at infant malformation rates as well as adverse events up to 28 weeks postpartum. So 91 mothers were screened, 20 were excluded due to incomplete data or loss to follow-up. So 70 mothers contributed data from time of TAF initiation to postpartum, and they gave birth to 73 infants, so 2 sets of twins, who contributed data from birth to week 28. And the maternal treatment effects for TAF were as expected. HPV DNA and surface antigen titers were lower at time of delivery. ALT was also lower, but not statistically significant. At delivery, although only 86% achieved HPV DNA less than 200,000, all pairs met their primary endpoint. So there were no mother-to-child transmission occurred, and there were no congenital abnormalities that were noted. And at 6 months, infants had comparable height, weight, and head circumference to national infant standards in China, and there were no serious adverse events. So the 66% that did breastfeed, this did not increase our risk of HPV infant infection. So in conclusion, TAF may be another option to prevent HPV perinatal transmission, but it does require more data and follow-up, given that we know that TDF is quite safe as well as cost is a lot cheaper. So the key clinical takeaways here are to consider entecavir or TAF for HPV treatment in older patients who may be at greater risk for renal impairment. We now know that long-term NA treatment reduces HPV DNA integration, which might be a mechanism for lower HCC risk on treatment. And data continues to emerge on the differential HCC risk reduction with entecavir compared with tenofovir, compared to entecavir, but I think it's still insufficient to really prompt changes in clinical management. And TAF is safe for prevention of mother-to-child transmission, although of course cost as well as the safety profile of TDF are still considerations. All right, so now we'll move on to withdrawal therapy. So the first study is the Stop Nuke trial. As we know now, long-term suppression of HPV replication can be, and discontinuation of NAs can result in durable immune control of HPV replication in ED antigen negative patients based on observational studies. So the Stop Nuke investigators in Germany wanted to look at the effect of NA discontinuation in a prospective and randomized fashion. So they started with e antigen negative patients without cirrhosis who had suppressed HPV DNA for at least 4 years on NAs. 83 patients went on to stop NAs, and 83 patients continued their NAs. They were all observed for 96 weeks or 2 years, and they had standard laboratory testing, including quantitative surface antigen. The primary endpoint was sustained surface antigen loss at 2 years. And secondary endpoints included seroconversion, virologic biochemical response, ALT flares, and retreatment. So their full analytic set were 79 patients in each arm. And at week 96, arm A, so the discontinuation arm, 10 patients experienced surface antigen loss. None of the patients did in the continuation arm. And of the 8 patients who had surface antigen loss, 6 went on to develop surface antibody at week 96. Now, they stratified these results by baseline surface antigen, and you'll see here in the group that had a baseline surface antigen over 1,000, only 1 patient went on to have surface antigen loss. All patients who discontinued did experience an HPV DNA flare of over 20 IUs per ml. Now, looking at their secondary endpoints, HPV DNA that was undetectable was seen in 31% of those who discontinued and 100% of those who didn't. ALT flares were seen in 35% who discontinued. They restarted NAs in 14%, but promisingly, 68% did not meet an indication to restart NA based on EASL recommendations, and no patient had a severe adverse event. So the Stop Nuke study is really the first randomized study to demonstrate the potential of discontinuation of long-term NA treatment for functional cure in E antigen negative patients. They observed surface antigen loss throughout the throughout the 96 weeks of follow-up. So they're continuing to follow these patients to see if more patients experience loss later on. Second study is a randomized trial that looks at 192 weeks of tenofovir with or without peg interferon alpha for the first 20 weeks, followed by a protocolized withdrawal. So this was presented by Dr. Turon on behalf of the HBRN and patients in the immune active trial. And what they wanted to look at was the safety and efficacy of this treatment regimen, followed by a very protocolized treatment withdrawal. And I'll talk about that protocol. So they included E antigen negative or positive patients who had active disease on either laboratory or histology, and they had no prior antiviral therapy for over 24 weeks. Their treatment phase was 192 weeks, which is about 3.7 years, and their withdrawal phase was 1 year. They enrolled 201 patients. About half were in the tenofovir arm and about half had tenofovir plus the 24 weeks of peg interferon. Now the withdrawal criteria they used were an HPV DNA less than 1,000 for 24 weeks. They could not have cirrhosis. They had to be E antigen negative by week 144 and have developed E antibodies by week 180. So that ended up leading to about half of the tenofovir only group being withdrawn and a little bit more than half in the peg interferon group. They retreated as well in a protocolized manner. So any patient who had clinical decompensation, a T-billy over 3 or a D-billy over 1, an HPV DNA over 10,000 plus an ALT elevation. And that ALT elevation differed by magnitude of elevation as well as timing of elevation. And their primary endpoint was surface antigen loss. So you'll see here that the cumulative incidence of surface antigen loss did not differ by treatment group. 6% in the peg interferon group compared to 5% in the tenofovir only group went on to have surface antigen loss. The difference is, as you'll see in this Kaplan-Meier, is actually when they lost surface antigen. So the peg interferon group, these patients were more likely to lose surface antigen earlier on in the treatment phase, whereas in the tenofovir group, most of these patients lost their surface antigen after withdrawal. And you'll see E antigen loss was slightly higher in the peg interferon group, although it was not statistically significant. And then the rates of HPV DNA less than 1,000 and normal ALT were similar. The timing of ALT flares also differed by treatment group. So in the tenofovir group, most of the flares occurred during the withdrawal phase, whereas in the peg interferon group, 58%, the majority of flares occurred actually in the first 24 weeks of therapy while on peg interferon. So none of these patients had any safety issues. So this really shows that with the protocolized withdrawal strategy, the withdrawal therapy is safe. However, the achievement of surface antigen was not significantly enhanced by the combination of peg interferon for 24 weeks plus tenofovir followed by withdrawal. The longer follow-up is still needed. Now, the RETRACT-B study looked at surface antigen loss in a large global multi-ethnic cohort of patients. And the idea is there's been a lot of heterogeneity in the studies that have looked at NA withdrawal, and rates of surface antigen loss have ranged from 0 to 47% across these studies. So there's really a need for analysis on a global scale so we have more robust statistical power. So this is an ongoing retrospective cohort study. Of patients who discontinued NAs between 2001 and 2020. There are 12 participating centers across North America, Europe, and Asia. They included anybody who was E antigen negative with an undetectable HPV DNA at time of NA cessation, although they could have been E antigen positive when they started their therapy. They excluded anyone who was co-infected and anyone who received peg interferon 1 year prior to cessation. The primary outcome was off-treatment surface antigen loss, as well as retreatment with NAs. He looked specifically at age, sex, race, type of NA, and their E antigen status at start of therapy. So there were 1,541 patients, mean age of 53, 73% were male. And of note, the vast majority, 88% were Asian, a minority, 10% were Caucasian, 2% were other race. Genotype data was missing for 43% of this cohort. As you can imagine, most of these patients had undetectable DNA at time of withdrawal. But of those that had genotype, 43% were genotype B. At start of therapy, 77% were E antigen negative, and 5% had cirrhosis. The majority were treated with entecavir, followed by tenofovir. Median number of follow-ups after taking off treatment was 5 visits over 17 months. Now, the cumulative incidence of surface antigen loss at 3 years in this cohort was 12%, and the retreatment rate was 50%. The only predictor of retreatment was age over 50 years. And of note, 15 patients did decompensate, and there were 12 deaths during follow-up, 9 of which were liver-related. And the interesting finding here was that the only independent predictor of surface antigen loss was race. So the likelihood was 6 times higher among Caucasians compared to Asians. You'll see that Caucasians had a 37% rate of cumulative incidence of surface antigen loss at 3 years compared to only 9% in Asians. So the study shows that stopping long-term NA is feasible, but we do have to closely monitor as there is a risk of a low of severe flares and death. And surface antigen loss appears to be higher in the study in Caucasians. And this does mirror some of the individual cohort studies that have demonstrated higher rates of loss in Western compared to Eastern cohorts. All right, this last study is focused on off-treatment ALT flares, and this has definitely been a challenge in withdrawal therapy of knowing when, in which patients ALT flares will actually occur and which ones end up being effective versus ineffective. So biomarkers for intrahepatic replication outside of HBV DNA are really needed because HBV DNA are low and undetectable at time of withdrawal. So this study looked at serum surface antigen, core-related antigen, and HBV RNA at end of treatment to see if it could predict ALT flares and virologic outcomes. So the participants were from 3 combined global RCTs of both e antigen positive and negative patients who either received peg interferon plus an NA or an NA with combination peg interferon add-on. They measured all serum biomarkers at end of treatment, so with at time of withdrawal, and then they followed up for 6 months to identify incident flares. And flares were defined as an ALT over 5 times upper limit of normal during those first 6 months after treatment cessation. So of the 344 patients, the median age was quite young at 34, 75% were male, majority, 52% were genotype D, followed by A, C, and B. So among this total group, 16.6% had a sustained response at 6 months, defined as an HBV DNA less than 2,000, but only 2% had surface antigen loss. ALT flare was seen in 36% of patients. And as you'll see here in this bar graph, categorized individual as well as combined biomarkers, that increased biomarker levels were associated with increased proportion with ALT flares, and this was statistically significant across all groups. In the scale B is actually a composite measure that the authors created that includes surface antigen, correlated antigen, age, and ALT. Decreased biomarker levels were also associated with increased likelihood of sustained response. Although interestingly, in this study, having an off-treatment ALT flare was actually associated with lower rates of sustained response in surface antigen loss. And those with surface antigen loss, it only occurred in patients with low levels of biomarkers at time of withdrawal. So the study demonstrates that novel biomarkers, when they become available, might be utilized in clinical practice to really select the patients that would benefit from finite therapy and also identify those that might require more close monitoring for flares after withdrawal. So this year, we've really had additional prospective and randomized data to support withdrawal therapy as a management strategy for HBV. And we've identified both host factors like race and viral biomarkers that predict the risk of flare and outcomes. However, there's still much that's not known, including the optimal timing of retreatment so that we optimize surface antigen loss, but also make sure our patients do not have decompensation or death. And close monitoring is absolutely essential to ensure patient safety if you are to undertake this method. All right, so moving on to novel therapies. So this is an overview of the current drugs that are in phase 1 or 2 trials, and they really target many aspects of the HBV viral cycle, from entry inhibition to secretion of surface antigen to blocking RNA translation and the assembly of capsids. There are also agents that target the innate immune system as well as the adaptive immune system, and the agents here in bold are the ones that I will discuss today. So the first therapy is J&J 3989, which is an RNA interference therapy. It does silence HBV RNA transcripts from both cccDNA as well as integrated HBV DNA, and therefore would have an effect on surface antigen in both e antigen positive and negative patients. In 2019, Dr. Game presented the results from the phase 2A study of J&J 3989 plus an NA and demonstrated the antiviral activity of this agent with reduction in serum surface antigen, HBV RNA, e antigen, as well as correlated antigen. So at EASL this year, they presented the 9-month follow-up data for those patients that received at least 100 milligrams of the agent. So there were 40 patients. They were e antigen positive or e antigen negative, NA experienced or naive, and they received 4 doses of subcutaneous J&J 3989 at varying levels, spaced 1 month apart. All patients either started an NA on day 1 or continued their NA, and this was continued throughout the study. They looked at safety and viral parameters, and for all viral parameters, a sustained suppression was defined as a greater than 1 log reduction from day 1 of therapy, or a value that was lower than the limit of quantification. So here are the patient demographics. 70% were male, 85% Asian, 65% were e antigen negative, and 80% were NA experienced. The good thing was there were no deaths, no treatment discontinuations, or any drug-related severe adverse events. And the most common AEs were really mild injection site irritation. And you'll see here that across the 4 different doses, the mean surface antigen nadir was pretty similar, at least 1 log. So 39 out of 40 patients, so 98% of patients did have the 1 log 10 surface antigen reduction that they were looking for. And then looking at the longer term follow-up data to 392 days, though those that had a response, 15 patients had a sustained response and 29% had a non-sustained response. And that sustained response was a less than 1 log 10 reduction in surface antigen. That was in sustained suppression of other viral parameters, HBV RNA, e antigen, and correlated antigen, were seen in 58%, 64%, and 42% respectively, among those that had a positive level at time of initiation of treatment. And the reduction in these other viral parameters were actually more pronounced in those who demonstrated a sustained response based on their surface antigen. So J&J 3989 was well tolerated, and 98% of patients achieved their primary endpoint of greater than 1 log 10 reduction in surface antigen at nadir. And then a subset, 39% of patients, had that sustained surface antigen suppression 9 months after the last RNAi dose. And this really supports their plan on continuing to look at this therapy with longer term duration. The next drug is also an siRNA, so another RNA interference agent, AB729. This particular agent uses a proprietary liver targeting technology and is delivered subcutaneously. In preclinical models, it did inhibit HBV replication, it reduced all viral transcripts and lowered all antigens, and was pan-genotypic. So Dr. Yuan presented preliminary safety and pharmacodynamic data on NA suppressed patients with chronic Hep B, and they looked at it at single and multiple dose regimens at varying levels and intervals. So this was a phase 1 open label study. We'll focus on part 2, which is patients who received single doses at 60, 90, and 180, as well as 7 patients who received 60 milligrams doses 4 weeks apart and received at least 4 doses. They included those between 18 and 65, at least 6 months on NA therapy, who had viral suppression and were not cirrhotic. So here are the outcomes. Looking at the mean surface antigen, this is important because at baseline, their mean surface antigen was a little bit different. The 180 milligram dosing cohort had the highest mean surface antigen levels, and the 90 milligram had the lowest. When you look at mean decline after 12 weeks, this was pretty similar across the dosing regimens. But then if you look at the proportion with a surface antigen less than 100, this was highest in the 90 milligram group and was not seen in the 180 milligram group, although that is likely due to their mean surface antigen at start of treatment. And then looking at surface antigen kinetics, you'll see here that with each dosing group, there was a steady decline in surface antigen until week 12. And with the single dose regimens, there was a plateau in response after week 12. Overall, the mean decline at week 20 for all three groups was negative 1.7 log 10 reduction. But for the repeated dosing group, the decline in surface antigen continued and there was no plateau observed to date. There were no severe adverse events or discontinuations, and the injection site adverse events were transient and mild. So for AB 729, mean surface antigen concentrations continuously declined up to week 12 before reaching a plateau. There was no clear dose response to this observation, and it really does support that this particular agent can have a dosing interval of greater than 4 weeks, and that's currently under study. The kinetics of surface antigen decline were similar between the single and repeat dose cohorts. So our next drug is a hepatitis B core inhibitor, so ABIH0731, that's administered with an NA in patients, here looking at patients with E antigen negative disease. So the core protein inhibitor works with several mechanisms. It disrupts HBV capsid formation by allosteric binding, which then blocks pregenomic RNA encapsidation and also blocks the formation of new cccDNA. So because of its mechanism, there isn't any direct effect on surface antigen. And you'll see that in how they present their results. This is an orally administered drug at 300 milligrams daily. The antiviral activity and safety for E antigen patients were presented here in a double-blind, placebo-controlled fashion. So they included patients with HBV DNA undetectable for over 6 months. They had to have a surface antigen that was over 1,000, an ALT that was less than 5 times upper limit of normal, and had to have no more than F2 fibrosis. These patients were randomized 3-2 for 24 weeks of treatment, either to ABIH0731 with an NA or placebo with an NA. And their endpoint was HBV DNA and pregenomic RNA using highly sensitive assays, given that they had undetectable DNA at start of therapy. And again, the endpoint was not surface antigen reduction or loss. The safety endpoints were any adverse events and any laboratory abnormalities. So subjects were predominantly male and Asian. Mean age was 48 years. And you'll see here that using both an in-house HBV DNA sensitive assay, as well as the COBA's TACMAN 2.0, that those who received ABIH0731 did, a higher proportion did have the target not detected at the lowest limit of detectability as compared to those who received placebo. The pregenomic RNA, though, did not seem different between the two groups. And then, as expected, at week 24, there was no decline in the core-related antigen as well as surface antigen in those who either received the agent or placebo. Adverse events and laboratory abnormalities were similar in both groups and were mild or moderate. There were no severe adverse events or discontinuations. So they concluded that 24 weeks of treatment with H0731 resulted in a higher proportion of E antigen negative patients achieving viral suppression by highly sensitive assays. So a very deep viral suppression compared with placebo and NA. And there was a favorable safety and tolerability profile. So longer term duration with these agents are really needed to see what the impact might be on surface antigen. Lastly, I'm presenting one adaptive immune therapy. A therapeutic vaccine containing surface antigen and core antigen called NASVAC. And this is a therapeutic vaccine that really increases HBV adaptive immunity, so T-cell mediated immunity towards surface antigen and core antigen. And the initial results of the NASVAC trial was presented in 2019 at AASLD with 6 months of follow-up, and they demonstrated a 16 to 18% reduction in surface antigen levels. So the goal here was to present the updated data on NASVAC now to 18 months of follow-up on surface antigen loss as well as seroconversion. So a total of 71 subjects received 10 doses of NASVAC, so it was given once every 2 weeks through an open label clinical trial in Japan. 29 patients were on NA therapy, 22 of those reached the 18-month mark, 42 were treatment naive, and 33 reached 18 months. Their outcomes of interest were reduction in surface antigen, surface antibody positivity, and surface antigen loss. So for the NA group, 70% were men, 75% were E antigen negative, compared to 50% women in the untreated group, and 95% were E antigen negative. Most of these patients were genotype C. There were no severe adverse events, and HPV DNA remained suppressed in the NA group and decreased about 19% in the treatment naive group. Correlated antigen did decline slightly, but this change was not statistically significant. So looking at surface antigen reduction, those who received NAs on the left, there continued to be a decline in the percent change in surface antigen at 18 months, so 25.1% compared to 15.7% at 6 months. Similarly, it was 27.5% decrease in those who were treatment naive. Overall, at 18 months for both groups, the reduction, the percent with the reduction in surface antigen, as well as the proportion with positive anti-HBs was not that different than 6 months, but there was an increase in surface antigen loss of 9% in the NA group and 12% in the treatment naive group. So Dr. Yoshida concluded that longer follow-up did show better outcomes in surface antigen reduction and achievement of surface antigen loss, although that achievement of surface antigen loss is still moderate. And nasal administration of NASVAC could be an effective and safe immune therapy for achieving functional cure. So there are many promising therapeutic options in preclinical phase 1 and 2 trials, and a few are entering phase 3. And I think the safety data on these new agents are quite encouraging. A combination of direct antivirals with or without an immunomodulator is likely the future of HPV therapy. And if you have any patients that are looking for clinical trials, antidote.me is a great resource to match those patients to local trials. All right, thank you. And these are some presentations that were still available on demand from AASLD that were really excellent, and I recommend you check them out.